Cervical cancer. Cervical cancer is going to be, from the word itself, it is a cancer of the cervix, affects the cervix, but of course it can spread to other parts of the female reproductive system. The major cause of cervical cancer is human papilloma virus, HPV. So without HPV, whatever we'll be talking about is not going to be cervical cancer as it stands for now. So if you are talking about cervical cancer, talk about HPV. The common age you can see it affects is people of an age as you guys, which is the young age, 20 to 35. The risk factors for cervical cancer, there are really a lot, and these classes come in a week, which is a cervical cancer week, which is being commemorated, and the news is everywhere. So females that are sexually active should actually be able to screen. Anyone that is sexually active should be able to screen because they are at risk of getting cervical cancer. So, what are the risk factors? The number one risk is infection with HPV. So, you have got a high risk HPV, especially 16 and 18. 16 that can cause squamous cell carcinoma and 18 that can cause adenocarcinoma, but they can cause any. These are not the only high risk HPVs. You also have got 31, 33, 35. So at least these are the common ones. 16, 18 are the most common, 31, 33, 35. And the way HPV causes cervical cancer is that it is going to affect the basal cells. And so you'll be able to see coilocytes. Other risk factors include the sexual history, someone that has got multiple sexual partners. I want you to correlate this with breast cancer because these are the major cancers in females. Breast cancer, the more children one has, the less likely they are to develop breast cancer. So multiparity is good for breast cancer, but it is actually bad for cervical cancer. So a lot of sexual partners having sexual relationships before the age of 16. And the reason as to why this is so is before puberty, the ectocervix, actually the squamocolumnar junction, we'll talk about it. It is inside the vagina. That's in the ectocervix. So it is more prone to changes because HPV infection is going to go on the squamocolumnar junction. That's why it will start causing the problem. So since the squamocolumnar junction is inside the vagina before se- uh, before puberty, that makes the condition to be high likely to happen in the young like this. So a patient or someone that has got a partner as a partner who has had sexual contact with a woman with cervical cancer is also at risk, but you will not know. So smoking can also be a risk factor. Weakened immune system, like someone that has got HIV, promiscuity, this is having a lot of sexual partners, several pregnancies, multi-gravida and multiparity. So multiparity, a lot, and multigravida. So these guys, a lot of pregnancies and a lot of children are actually a risk factor. Opposite to breast cancer, as we said. Giving birth at a very young age is also a problem. Again, opposite to breast cancer. History of having other sexually transmitted diseases is also a risk factor. Actually, giving giving birth at a young age, long-term use of oral contraceptives, it is associated with adenocarcinoma, which is a type of cervical cancer. Please try by all means to avoid using these drugs. So, in case you can't avoid sex, let the child be born so that we know. Family history. of cervical cancer, vitamin deficiency, and the low socioeconomic status. And how socioeconomic status is going to lead to cervical cancer is you have got someone that doesn't have money, so they are trying to look for money. They end up having being involved in things like prostitution, and that is having different men coming, and because of that, they can get HPV. The clinical features of someone that has got cervical cancer, there is going to be abnormal vaginal bleeding, and it initially starts as watery bleeding, which is red or brown, and it has got a very bad smell. This is actually the most common presentation, abnormal vaginal bleeding. And then there's going to be vaginal discharge. The discharge, this is a bloody stained and more frequent. It's blood stained, the discharge that has got blood. And it is frequent as the disease gets to progress. Okay. And you are going to be seeing this discharge after sex or between the menstrual cycles or after menopause, postmenopausal. There can also be dyspareunia. I don't know how you're going to pronounce that, or dyspareunia. So this is pain when sex is happening. And then dysuria, which is pain on urination, vaginal discomfort or pain, pelvic and back pain, loss of appetite, and because you have lost appetite, you're also going to lose weight. So that's also another clinical feature. Of course, it can be non-specific. In advanced diseases, the patient may experience edema, low in pain, rectal bleeding, radiculopathy. This is where now the nerves are affected. When the nerves are coming from the spinal cord, at that point where they're coming from the spinal cord, can be inflammation, hematuria. And these effects, can you see there is involvement of other parts of the body. So this happens when the cancer has now started invading nearby structures. Before someone has got cervical cancer, they can have other lesions. That can mean that later on they are at a more higher risk of getting cervical cancer. Cervical dysplasia. Dysplasia, this is where you just have abnormal division of cells and they are not doing it right. Cervical intraepithelial neoplasia and squamous intraepithelial lesion, atypical glandular cells, polyps, warts, cysts, these can all be precancerous. If someone has got them, it might mean later on they can have cervical cancer. Again, how is cancer going to develop? You have got normal cells. Later on, these cells will start to divide abnormal. They'll start dividing first, that is hyperplasia. And then now they will now start dividing uncontrollably and in unregulated fashion, that is dysplasia, and then they can now end up spreading. That will be now the cancer. So that is how cervical cancer also happens. So you have got grades. Now before you can have cervical cancer, you first have what we call the C cervical intraepithelial neoplasm. Okay, this is before cancer. So if someone has got this condition, it means that later on they are likely to develop cervical cancer. So cervical intraepithelial neoplasm, you have got one, two, three. So one, cervical intraepithelial neoplasm, one is mild dysplasia. The cells are dividing abnormally. Now, when someone has got HPV, what happens that we said that HPV will start it to infect or it to cause problems to the basal cells. So you are starting on the base. So if there's abnormal proliferation of the base, the cells at the bottom, but only one third of the cells at the bottom are dividing abnormally. That is CIN1, cervical intra cervical intraepithelial neoplasia 1. And then for 2, it is a moderate dysplasia. This involves between one third to two thirds of the basal cells being affected. Remember, the thing is, you are starting from the base. Cervical intraepithelial neoplasia 3 is a severe form, and this one, there is dysplasia for the entire thickness of the cervix. And then this cervical intraepithelial neoplasia 3 is also known as carcinoma in situ. Okay, so this now can go into cervical cancer later on. So each one of these stages has got a higher percentage of developing into cancer. Like CIN3 has got a much higher percentage in developing into cervical cancer than 2, and 2 a higher chance than 1. Okay. So this is what happens. Here is our normal cell. You can see for CIN1, only 1/3 of the basal cells are affected. CIN2, between 1/3 and 2/3. CIN3, you have got the severe dysplasia where nearly every all the cells are affected, and then you have got carcinoma in situ where everything, all the cells are dysplastic. But when these dysplastic cells now start to spread, you know that is a characteristic feature of a cancer spreading, then that will now be the squamous cell carcinoma, which is the invasive carcinoma. When you are grading these cancers, cervical cancers, you can look at first the type that you are dealing with. I should mention, okay, we can just mention it here. Remember we talked about the squamocolumnar junction? On the outer aspect of the squamocolumnar junction, you have got ectocervix, that is the vagina. And then the inner aspect, you have got the endocervix, you are going into the uterus somewhere there. So if you have what is involved, remember the epithelium of the vagina is the stratified squamous, while the epithelium of the uterus, the cervix, is going to be the columnar epithelium. So if what is going to be involved will be the ectocervix, where I've got a squamous epithelium, that will be known as squamous cell carcinoma. So that will be the cancer, that the cervical cancer. But if the epithelium that is involved is the one that is inside endocervix, which is the columnar epithelium, that is going to be adenocarcinoma. So also the classification, when you look at the classification for cervical cancer, the cervical intraepithelial neoplasia, okay, so you can see dysplasia. If there is mute dysplasia, you have got CIN1, only 2/3 of the cells are affected. Moderate is CIN2, severe is CIN3. That is, of course, going to also go into the carcinoma in situ. So the squamous intraepithelial lesion classification, when you have got CI1N1, CIN1, that is a low grade squamous intraepithelial lesion. The rest are going to be high grade. Again, this is just the same thing that we have said. Only the mild dysplasia is low grade when it comes to the squamous intraepithelial lesion. The rest are high grade. How do we stage cervical cancer? It is staged using the International Federation of Gynaecology and Obstetrics, which is known as FIGO. FIGO classification or staging of cervical cancer. The stage 0 is the CIN3, which is carcinoma in situ. Stage 1 is the cervical cancer that is confined to the cervix. Now, for each one of these, you have got 1A and 1B. So, the one that is confined to the cervix, you have got stage 1A. Stage 1A, that one is a microscopic disease. You can only see the cancer by using a microscopy. This is invasive carcinoma but not diagnosed unless by a biopsy. 1B is macroscopic disease. It can be visible by the eyes. Okay. And then stage 2, this is where now the cancer goes beyond the cervix but not pelvic side wall. It has gone beyond the cervix but it hasn't gone. In other words, it hasn't involved the lower part of the vagina. Remember the cervix is on top, isn't it? So you are going to involve the upper part of the vagina, but it doesn't go to the very bottom of the vagina. So only the upper two-thirds of the vagina is involved, not the lower one-third. So stage 2A, there is infiltrative involvement of the upper two-thirds of the vagina, and then 2B, you also infiltrate parametria, the surrounding tissue there. And then in stage 3, there is now the extension or infiltration of the pelvic side walls and including the lower one-third of the vagina. And there's also going to be non-functional kidneys or hydronephrosis, the water going piling up in the kidney. So stage 3A, there's infiltration of the lower one-third of the vagina, and then stage 3B, there's the infiltration of the pelvic side was associated with also hydronephrosis. Stage 4, this is where now the extension goes to the bladder, the rectum, and there is distance metastasis. So stage 4A, there is involvement of the bladder, the rectum. Stage 4B, there's now metastasis. This is where the cancer goes to distant organs. Okay, this is what we're talking about. You can see for the one, this is the one that is just confined to the cervix alone, just here. That's 1A. The 1B, it will now start going a bit down. So just like that, you can see by the time you are reaching 3, there is involvement going also on the side walls of the cervix. So cervical cancer, as we said, is of two types. You have got the squamous cell carcinoma and the adenocarcinoma. Squamous cell carcinoma affects the squamous cells that is in the vagina or the ectocervix, and it's the most common type. Adenocarcinoma begins in the columnar-shaped granular cells, which is part of the endocervix. So ectocervix is squamous cell carcinoma, endocervix is adenocarcinoma. What causes cervical cancer? The etiology. There's going to be, it begins with the healthy cells in the cervix undergoing a mutation. And that mutation normally is because of the HPV virus, and that is going to be able to cause this abnormal division. You can see here, you can see the squamocolumnar junction at this point. This is going to be the vaginal end where I've got the stratified squamous epithelium, and then going inside, that is going to be the endocervix where I've got the columnar epithelium. So the pathogenesis, the main site for the cancer is the transition zone, also known as the squamocolumnar junction. Because this point is highly mitotic, there's a lot of cell division happening there. So what is going to happen is that in young females, this junction is actually in the ectocervix, it's in the vagina, as we said earlier on. That's why sex before puberty is more likely going to cause cervical cancer. Okay. In the presence of HPV infection, in addition to other factors, like smoking, metaplasia will change to dysplasia. Metaplasia is normal division of cell. Because actually what happens is this. I should have put a nice diagram. As females get to grow, what will be happening is that there's going to be rolling of the cervix. That part that was in the ectocervix is going to roll out. It comes into the vagina as endocervix. And what should happen is that because it was inside the cervix and it is rolling out into the vagina, it has got a columnar epithelium. And so what should happen is that that columnar epithelium should change into stratified squamous epithelium because of the change of environment. That is normal. That is metaplasia, the change uh, of the epithelium. But then this change of epithelium can become dysplastic. It can become unnecessary changing of epithelium, and that is what is going to drive to the formation of cervical intraepithelial neoplasm. Okay, you can see what I was saying. The green here is representing the endocervix, the blue is the ectocervix, the yellow is representing the squamocolumnar junction. As females get to grow, there's going to be rolling. This green part that you can see will be rolling out, coming into the vagina. And so epithelium has to change. So how does cervical cancer happen? The first thing is that there is actually exposure to someone has got some sexual activity, there's exposure to HPV. This HPV is going to cause transformation in the transformation zone, cervical transformation. If it is affecting the squamous epithelium, it's going to lead first to squamous intraepithelial lesion starting from the base, CIN1, CIN2, CIN3, which is carcinoma in situ. You have got the low risk HPVs like 6, 11, 42 to 44, but these are rare to cause cancer. And then you have got the high risk 16, 18, 31, 33, 35. These are the ones that cause more cancer, especially when you have got other factors like smoking, oral contraceptives, high parity, altered immune status, host gene alteration, and also a prolonged period of time, right? This can now, so from the squamous intraepithelial lesion, you can now go into invasive squamous cell carcinoma. If it was endocervix which was involved, there's going to be the granular intraepithelial lesion. This is intraepithelial lesion involving the granular cells, which is the columnar cells, and that is going to cause also adenocarcinoma in situ. Okay, and that can as well with other factors go into invasive adenocarcinoma. So it all starts as the carcinoma in situ, which is not really the cancer that is not metastasizing, and then it can now become metastatic. So step by step pathogenesis, there is sexual intercourse with, and so someone as is exposed to high risk HPV. With the exposure to the high risk HPV 16, 18, 31, 33, 35, what happens is that these HPVs will produce E6, which is their enzymes E6 and E7. These are oncoproteins. They play a very important role in cervical cancer. And what happens that E6 is going to bind and promote degradation of the tumor suppressor protein P53. Remember, this one suppresses tumors. So E6 suppresses P53. And so P53 prevents abnormal division of cells. And the P53, what it does is that when cells are abnormal dividing, it will initiate apoptosis. So without that, please, you can as well follow the videos on genopathology. I've posted them on the same drive for genopathology so that you can follow them properly. So there's going to be prevention of apoptosis because we have inhibited the tumor suppressor gene. And that is going to allow uncontrollable cell proliferation. What E7 does is that it inactivates the retinoblastoma protein, PRB, and this protein, what happens is that when it is inactivated, there's going to be release of E2F, transcription factor. And when this E2F has been released, what happens that is going to be promotion of the cell cycle progression. You have inhibited what was supposed to be destroying abnormal proliferation, and then you have stimulated something to stimulate the continuation of the cell cycle. And what that does is that there's going to be uncontrollable division. So what happens that the HPV will initially bind to the heparin sulfate proteoglycans that is on the cervical epithelial surface. And once the binding happens, so binding will trigger conformational change in the viral caspid proteins L1 and L2. These are important. These L1 and L2 are important or necessary for the interaction with the uptake receptor. That is for HPV adherence to the cervical epithelium, right? So HPV is going to enter the cell using the clathrin independent endocytosis. The L2, what L2 is going to be doing is that it facilitates escape from the endosome. Remember, initially, when you have got viruses and other microorganisms, they're going to be taken by the endosome and to form a phagosome and then taken to the endosome, forming the phagolysosome to be destroyed. But L2 helps in stopping that. L1 is normally helping in adhering to adhere to the epithelium of the cervix, helping the virus to adhere there. So the viral genome, therefore, is going to be transmitted to the nucleus and then it will integrate with the host DNA, and that will now initiate the oncogenic process, which is the inactivation of P53 and PRB. And that is going to lead to increases cell proliferation and genomic instability. The infected cells are going to acquire the ability to divide indefinitely, which is a hallmark of cancer. So that is the pathogenesis. And then this CI cervical intraepithelial neoplasia can now undergo a series of changes from CIN1 to CIN3, which is the high grade, and CIN2. These guys now can go into invasive cancer. So the cancerous cells will now invade the basement membrane, and it will in the underlying stroma, and that will lead now to the invasive cervical cancer. Metastasis is going to happen via the lymphatic system and the blood going to other regions of the body. So that is a pathogenesis. How can we prevent cervical cancer? Vaccines like Cervarix can protect against HPV 16 and 18. Gardasil can protect against HPV 16, 18, and the other low risk HPV. So you can say that Gardasil is better. Avoiding smoking can also help because it is also a risk factor. Abstaining from sexual intercourse, delaying the first intercourse. Well, you are preventing cervical cancer. Let's hope you not end up with breast cancer, right? Because for breast cancer, the earlier the better, different from cervical cancer. But delaying first intercourse instead of doing it before puberty can also help. Using condoms during intercourse, because that is going to limit at least the HPV from interacting with the epithelium, and also having only one sexual partner who is faithful. Complications of cervical cancer: someone that has got cervical cancer can have constipation, urinary obstruction, hematuria, pain, leg edema, hydronephrosis. And how hydronephrosis is happening is because when the cancer happens, the cancer is going to block the ureters where urine passes from the kidney to the bladder. And so urine will start going back to the kidney, and that will cause excess fluid in the kidney. Diagnosing cervical cancer: you can use history, physical exam, a pap smear, okay, where you are getting some cells. You can also do some blood tests, DNA tests, biopsy, and radiological exam. And the management of cervical cancer: there is chemotherapy to kill the dividing cells, radiotherapy, surgery, also targeted therapy, giving drugs that are with one specific property or function rather than kill all rapidly growing cells. Targeted therapy is targeted for the cancer, but the chemo is for the entire body. You can also give immunotherapy to suppress some in case the immune system gets to respond too much. Right? So that is it about cervical cancer.